Good evening, everyone, and welcome. My name is Heather Cooper Ortner, and I'm the President and CEO of the IMF. It's a pleasure to have you with us for today's webinar and on the highlights from ASCO, EHA, and the 17th Annual IMWG Summit. The pace of change in myeloma has been extraordinary. Over just the past month, we've seen important new readouts across the spectrum of disease, from frontline risk-adapted strategies to MRD-driven approaches to rapidly evolving cellular and immune strategies in the relapsed and refractory setting. Our goal today is to make sense of these new data and, most importantly, talk about how they should influence everyday clinical practice and future research. So a few quick housekeeping notes before we begin. First of all, many thanks to our sponsors for this evening's webinar. We are sincerely grateful for the support of GSK, Johnson & Johnson, and Sanofi. Thank you all for your support. Tonight's program will start with a moderated discussion, and then we'll leave time for audience Q&A. You can begin dropping them into the Q&A box, and we'll be collecting them throughout the discussion. Please type your questions into that Q&A box, not into the chat. We won't be able, your speakers, the doctors joining me will not be able to see those if they're in the chat. And we'll do our best to address as many as we can later in the program. This session is being recorded, and a replay will be made available after the event. To understand why the data coming out the last few weeks is so significant, it's helpful to take a look at the different missions of the three major meetings that we're covering today. So ASCO is the American Society of Clinical Oncology, and this was their annual meeting. It is the world's largest gathering of oncology professionals because it covers all cancers, solid tumor and liquid alike. The myeloma data presented here is often practice-changing. ASCO is where we see the primary results of massive phase 3 randomized controlled trials, such as the IMROZ data. And that often leads directly to FDA approvals and changes in how we treat patients in the clinic. EHA is the European Hematology Association Congress, their annual Congress, while ASCO is broad and EHA focuses specifically on blood disorders. This meeting provides more specialized look at hematologic malignancies, and it's often the venue where we see crucial updates on European-led trials, longer-term follow-up data on immune therapies. It provides a vital global perspective, highlighting the different healthcare systems and regulatory bodies and how they're integrating the latest drugs. And then there's the 17th Annual International Myeloma Working Group Summit. Unlike the large public conventions of ASCO and EHA, the IMWG Summit is a private think tank style gathering of 120 of the world's top myeloma specialists, including our guests today. The purpose of the summit is not just to view data, but to reach consensus. This is where the world's leaders debate the nuances of the data and create official guidelines on how to define risk, how to define strategies, risk stratification, and how to monitor the disease going forward. If ASCO and EHA provide the evidence, the IMWG Summit provides the roadmap for the future. And we are truly fortunate to be joined by three of the leaders in this field. Joining us this evening are Dr. S. Vincent Rajkumar from Mayo Clinic, whose work has shaped how treatment guidelines worldwide are implemented in the clinic. Dr. Rajkumar is the chairman of the board of the IMF, as well as chair of the IMWG. Dr. Sagar Lonial from Emory University and the Winship Cancer Institute is a driving force behind many of the frontline and relapse regimens we use today, and a key voice on how to integrate complex data into real-world practice. Dr. Nikhil Munshi from Dana-Farber Cancer Institute and Harvard Medical School is a global expert in the biology of myeloma and a pioneer in cellular and immune therapies, as well as a leader within the International Myeloma Working Group. All three are members of the IMF Board of Directors, board of our Scientific Advisory Board, and recognized leaders across the field. So gentlemen, we are coming off a marathon of science. While ASCO gave us the heavy-hitting phase 3 results and EHA provided the deep dive hematological updates, the IMWG Summit allowed the experts, you, to sit in a room together and ask, so what does this really mean? So let's jump right in and focus first on frontline therapy and the curative approach. So Dr. Rajkumar, for you first. With the updated data on quadruplet regimens like DVRD or ISA-VRD, are we finally reaching a point where we can standardize a one-size-fits-all frontline approach? Or does the recent EHA data suggest we should be more nuanced with risk stratification from day one?
Myeloma is not, first of all, thanks so much for having me. And I'm really honored to be along with Dr. Nikhil Munshi and Dr. Lonial. Myeloma is not a one-size-fits-all disease at all. I mean, based on frailty, based on transplant eligibility, based on risk status, performance status, we modify therapy all the time, and we should, so that patients get the best outcome. But by and large, unless patients are frail, we do start off with a quadruplet. And if patients are transplant eligible, we do consider a transplant. And at least for me, in the high-risk patients, I view that the transplant would be very important. Whereas in the standard risk patients, we do have a patient-shared decision-making. And then for maintenance, for standard risk, at least one drug, and for high risk, at least 2 drug maintenance. That's kind of where we are. We'd like to get everybody to MRD negative. And with this kind of an approach, for patients over the age of 65, about 70% can be progression-free at 4 years, and 80% for patients less than 65 can be progression-free at 4 years, with survival rates of 80-90%, which is remarkable. We want to see if these can be translated into cures down the road, and it'll take some time to figure that out. But the fact that we are talking about what does the cure definition mean tells that we are there, or at least we are very close.
Thank you, Dr. Rajkumar. That was wonderful. Dr. Munshi, as a follow-up to you, from a genomic perspective, are we seeing any data that tells us which patients won't respond to these more aggressive frontline quads? And is that a way that we might want to change our initial strategy?
Dr. Rajkumar said it's my pleasure being here, and we have a large gathering, and we are excited to share what has been presented in more recent meetings. It's really good progress happening literally every 3 to 4 months. So to build on what Dr. Rajkumar's answer is, the treatments remain same, whether the patient is high risk or not high risk based on genomic features. And now we have, as part of the IMWG's effort, we have standardized the new definition for who would be called high risk. The responses would end up being judged in the similar way. The question ends up being, do we do anything different with them? And in starting out, at the current moment, we do standard things, same 4-drug regimen. It includes anti-CD38 antibody, it includes immunomodulator, includes proteasome inhibitor. And there are different ones, but combined in the same way. What we do change and what we do see differently is that the frequency of response as measured by MRD could be different in high risk versus patients who are standard risk. And if you do not get MRD negativity, this is where we begin to sort of individualize. We would do transplant for sure in high risk patient because that's what gets us to MRD negativity in higher proportion of patients. We would change the maintenance. Instead of 1-drug maintenance, high risk would end up getting 2-drug or even sometimes 3-drug maintenance. And so this is where we would begin to use the genomics data and the biology to impact the disease and decrease the relapse and or extend their progression-free survival, taking them to the cure.
So thank you. Moving on a little bit past frontline and looking at the evolution of immunology, Dr. Lonial, the monumental 3 data on talquetamab, the combinations, They show a staggering 81% two-year PFS. How do you see the bispecific combinations fitting into the first relapse setting compared to traditional POM-based triplets?
Yeah, thank you very much, Heather, and it's great to be here with my colleagues. I'm going to actually take a slightly different spin on the last question you answered, and then get to your question. What really excited me about the IMWG Summit was all of the discussion around the curative possibilities for what we have in myeloma therapy in 2026. And unfortunately, that means we're going to have to wait a long time to see if our current definition that the IMS is putting forward actually fits and makes sense. But the fact that we're having those discussions is really, really exciting. And while I certainly do support the idea that transplant for high risk offers significant benefit, I would argue in the standard risk patient, they may be the subset that's cured if you transplant them in first remission. And certainly, I think all of us have patients who are 10 and 15 years out in ongoing complete remission who had consolidation with high-dose melphalan as part of their treatment. So I don't want the only take-home message to be, you can think about it if you're standard risk. I think there are real benefits to transplant in first remission, even for standard risk. So to get to your question about talquetamab and the Monumental 3 data, I think we've seen a number of trials now looking at both BCMA and GPRC5D targeted therapy in early relapse. We saw Majestic 3 last year. We saw Majestic 9 at ASCO this year using single agent teclistamab, and then we saw talquetamab in combination with DARA or combination with pomalidomide also showing pretty significant activity. And what I think these have demonstrated to us is that in the context of first relapse, our goals of therapy should be similar to our goals in the context of newly diagnosed myeloma. That our goal should be to achieve very deep remissions that can, in fact, be almost as durable, if not more durable, than we saw in frontline therapy. And I think that really means that using the bispecifics is one way to get there, but there may be other emerging ways to get there, with including things like CAR T cells or cell mods that may also help us to get there in the near future as well. So there's a lot of excitement about what to do in the context of first relapse to maximize that first remission duration.
So thank you. That's actually a wonderful lead into my next question for Dr. Munshi, which is we've also seen incredible results from CARTITUDE-4 and KarMMa-3 follow-ups, and looking at the EHA data on GPRC5D targeted CAR Ts like Arlacel. Do you see a future where we sequence different CAR Ts, or are bispecifics going to kind of take over that earlier line of therapy position?
Yeah, so thank you for that question, because that's the commonest question we all face from various groups, the sequencing of immunotherapy. So we are so pleased and lucky that we have many good options. There are CAR T cells which function very well, and the bispecific almost do the same thing. And so which one should use having the same target? And in general, the answer is that if everything equal, the patient's general condition, frailty, and also access, then CAR T is a preferred first-line treatment for very many good reasons. It provides deep response, much higher frequency of response by itself. And when CARTITUDE-4 and KarMMa-3 studies were done, this was very clear, because CAR T cells would give you 90 to 95% response rate versus bispecific would be a little bit on the lower side. The field is changing in the sense that now we combine it with daratumumab, and when you combine teclistamab with daratumumab, the responses are very similar to close to 85-90% in a real-world setting, and also progression-free survival is outstanding. And so there is a competition between CAR T cell or combination bispecific. Because CAR T cell currently still is one and done phenomenon, and it does provide deep responses, MRD negativity in a large number of patients, that is in general preferred at the moment. The field is changing as we have more data about the bispecific combination, etc. We may have a different suggestions for different patients, depending upon the risk, depending upon the access, depending upon the prior exposures, if they had daratumumab before or not, or sensitive or resistant to it or not. Slightly complex decision, but a simple answer would be that if given a choice and everything equal, currently we would consider CAR T cell as a preferred option. And the bispecific can still be utilized later on, and we can switch the target. If you use the BCMA targeting CAR T cell, we can use bispecific with talquetamab as a second line. And if you use in future GPRC5D targeting CAR T cell, we may end up using BCMA targeting bispecific later on. So the good news is we are it's a problem of richness. We have so many good options, and we can tailor it to patients' various situation. CAR T being preferred first option if that is possible.
Thank you, Dr. Munshi. So, Dr. Rajkumar, a slightly different spin on our talk about these immune therapies. As we see more and more of them coming through in trials and more data readouts, we're also seeing unique toxicities. What are your thoughts on long-term usability of these therapies regarding patient quality of life and also toxicity to the healthcare system and to other systems outside the US? We know that access is also a challenge. And so getting access and managing these toxicities long-term, what are your thoughts on what the future looks like for their use long-term in patients and widespread?
So as far as the toxicities go, Heather, I mean, when we first had bortezomib, 2002 or something like that, the thinking was that you cannot give more than 8 cycles because it's just too toxic. And we learned to use that drug. So I have patients taking it 5 years, 8 years and more, because we know we can give it once a week and subcutaneous and then delay the treatments to get minimal toxicity. We've learned to use carfilzomib well. We've learned to use dexamethasone well. And I think we will. If you just did it exactly as the label dictates, you will probably have higher toxicities with these bispecifics, given weekly indefinitely or every other week indefinitely. But we will learn how to use these in terms of how often to give them, when to back off, when to even stop. And so I think, though the toxicities seem to be a major risk at this point, I think in a couple of years when we are much more comfortable with the dosing, the schedule, and when to stop, we will see a marked reduction in toxicities. Secondly, we are also getting more familiar with how to prevent them, like prophylactic tocilizumab to prevent the CRS rather than treating it afterwards, like giving IVIG before rather than after, or giving it routinely rather than based on the IgG level. So we will find ways in which we mitigate these side effects. And that's what we have done. That's what I'm sure we will do. So I'm not too worried about that. We are worried about some CAR T-related toxicities that we are still figuring out. But every day we are doing research to find out how to mitigate like neurotoxicity, delayed neurotoxicity with CAR T. I would say stay tuned. And there are more and more improved versions of these treatments coming out as well. That will be another way to reduce toxicity. Access will be a challenge to countries where the cost of these drugs is just prohibitive. And just like we have done with Len, Palm, Dara, and other things, over time, I think the access will get better as these products are on the market longer and they are competing for the same population, like 3 bispecifics against BCMA. There's going to be access opening up in other countries. And I'm just hopeful. The field is just going on so fast that the best way to bring down cost is to have many options for first relapse so that they can potentially compete on price, if not in the US and other parts of the world where they are still price sensitive.
Thank you. That was a wonderful message, I think, for our patients and care partners who are joining us this evening, a message of hope that in time, all of these things will be addressed and that there's even more potentially better opportunities coming in the future. So let's take a slightly different shift again and talk about high-risk disease and specifically about smoldering myeloma. Let's stay with you, Dr. Rajkumar. So the ASCENT trial updates that were presented at ASCO by SAB, our Scientific Advisory Board member, also your colleague at Mayo, Shaji Kumar. Those were reported at EHA. That was a big highlight. Are we officially at the point, do you think, where watch and wait is no longer the standard for high-risk smoldering myeloma? Or do you think there's still a role for the watch and wait for some?
I'm sure there's still a role for watch and wait for some. I don't think we should be categorical about that at this point. For right now, what we've done is to first find out whether early intervention in high risk prevents myeloma and delays the need for full-blown myeloma therapy and prolongs overall survival. The Aquila trial with daratumumab shows that it's potentially possible. And based on that, the FDA and the European Union have approved the drug, and it's recommended to be considered for high-risk smoldering myeloma. But a lot of factors go into account in that. How high risk is high risk? How long has the patient had the smoldering myeloma? If the patient's been high risk for 4 years, then they're no longer high risk, really, even if they meet the criteria. So we do individualize treatment. We also talk to the patient about pros and cons. The ASCENT trial is different. The ASCENT trial is a clinical trial, and that is testing the hypothesis that early intervention with not just one drug, but a myeloma-like intensity of therapy can potentially cure patients and prevent myeloma from happening once and for all. We won't know the answer to that question for many more years because we know that we can get deep responses. We know we can get most patients into MRD negative state, but will they stay negative after we stop therapy 5 years, 10 years down the road? That will be the surrogate for cure. Will take time. So as long as people recognize the ASCENT trial, the CAESAR trial, these are hypothesis testing trials which have read out the MRD level, but question of whether early intervention cures myeloma is unanswered. But we are not stopping there. We are continuing to do ASCENT-2 and other trials to figure out. And as we do these more and more, at some point, we'll be able to answer that question.
Thank you for that. So, Dr. Munshi, over to you. So at the IMWG Summit, there was a lot of talk about the ultra-high-risk patient. Are we any closer to biology-driven treatment path for these patients, specifically for that ultra-high-risk patient and the challenges that population has in being treated?
Yeah, so that's a very niche, small group of patients that constitute usually less than 10%, usually 5 to 7% of the patient, which are within the high-risk group, which usually constitutes around 20 to 25% of the overall population, who have more than one feature. And we're going to meet as part of IMWG and IMS and work to define how do we define the new ultra-high risk. So the good news is, just to get away from answering your question, is that as we come up with new treatment, the definition of risk changes. Why are we meeting to decide what is high risk again and again? Is because new treatment is able to overcome some of the risk features, and what used to be high risk 5 years ago, not today, is not a high risk. We have different groups of patients. So back to your question, ultra high risk patients are those who are still not doing as well as high risk patient, and definitely not anywhere near where standard risk does. So we have recognized that these patients do need more intense treatment, more focused treatment. And this is where a lot of genomic research is ongoing to define who are these patients, what drives the disease to be high risk, what makes them not as sensitive to current treatment, and we can overcome those resistance mechanisms. This is the group where we are more willing to take higher risk, utilizing CAR T cells, immunotherapy more upfront. And those studies are in a smaller subgroup of patients, is already ongoing, or we are analyzing the data from already patients who have had these treatments and are defined now as ultra high risk. So I think even for these patients who otherwise have not as good outcome currently, it is improving with treatment. And so I would not yet define what do we do? How do we treat them currently? But it is a great area of ongoing research where we are beginning to bring the immunotherapy as early as we can, or as early the accessibility to those drugs allows us. So at the bispecific CAR T cells, combinations of them, and that's going to change how those ultra high risk patients would perform on a long run.
Thank you, Dr. Munshi. So, Dr. Lonial, mezigdomide and other CELMoDs are also showing great promise, especially with the data that's come from the successor trials. Where do the oral agents, in your opinion, where do they fit into the increasingly infusion-heavy treatment landscape? Obviously, oral has a great appeal to patients. Do we see the same efficacy in the orals as we do with the infusions?
Yeah, thanks. I think that's a great question. And, mezigdomide and or iberdomide are both sort of new generation, what's called CELMoDs. And they do have the ability to more potently bind the same target as lenalidomide or pomalidomide, but do it with much more rapid impact and do it with much more potent immune stimulating activity. So I think that while certainly bispecifics and CARs have very encouraging data in early relapse, not every patient is going to necessarily have access to these treatments. And so having alternative newer approaches such as Mezi or Iber in this context will offer even those patients where CARs or bispecifics are not necessarily easily attainable. It'll give them other really good and effective regimens to use with a different adverse event profile. At the same time, where I think they're going to fit, quite honestly, is in partnership with all of these new immune therapies. I think combinations of Iber and Mezi are going to be great partners for bispecifics. I think they're going to be great pre or post CAR T cell approaches to enhance immune function and to enhance immunity. And at the same time, they have a much better adverse event profile than lenalidomide or pomalidomide, making them easier for patients to take over the long term. Now, again, just to sort of segue from the high-risk discussion that we had before, what is somewhat unique about Mezi is that it does appear to have activity in high-risk myeloma, particularly extramedullary disease. There's a very strong signal, which we have not seen with the previous IMiD class of drugs. And I think this to me is really encouraging because as we think about strategies of combinations to treat high-risk disease, either if it comes back or in the maintenance setting, I think it's going to include these new CELMoDs as part of the approach. I also think it's going to include those BCMA-directed therapies, which, at least in preliminary data, seem to be making a bigger difference than the old school proteasome inhibitors and IMiDs that, while they're effective, may not be getting us where we need to get with that high-risk subset.
That's a great answer. Thank you so much for that. I think that a lot of this conversation so far has done a lot to contribute hope to everybody who's joining us. And so I think that's really so far the message that I'm taking from all three of you, which is that there's so much progress in that there's options for each individual patient, and that in working directly with their healthcare provider, they can create a strategy that is uniquely that will uniquely address their myeloma. So I want to keep us all together here and and instead actually open this up for more of a group conversation, because there's been a lot of talk. There's been a lot of talk about cure. There's been a lot of talk about MRD and MRD negativity, and there was a lot of discussion at the IMWG Summit that talked about the future of MRD negativity and what that really means in terms of it being used as an endpoint in clinical trials and as a measurement for patients and doctors to understand their disease on an ongoing basis. Is MRD negativity in your minds? Is it now the endpoint? Is it the key thing that we should be watching? Is it what matters most is it what patients should be focusing on or not? Are we overemphasizing MRD in any way? And if by pushing to achieve MRD negativity, is there any risk this is a big question for all three of you to toss around. Is there any risk that we could be over-treating patients in our pursuit of MRD negativity? So I'll leave it there and invite you all to jump in and share your thoughts on this.
Well, I'll start. I think the main thing to keep in mind is the MRD negativity has many purposes, and depending on what purpose you're using that endpoint for, the metric has different values. Like you mentioned, we want MRD negativity to be a surrogate endpoint for new drug development, for new drug approval. That speeds up new drugs coming to the market, and we have emphasized that to regulators in the US and in Europe because it's generally a really good surrogate for PFS and potentially overall survival. We are also using MRD negativity that has been sustained for many, many years off all therapy as a potential surrogate for cure. We won't know for sure, but that's what our hypothesis is. We are already well aware that MRD negative patients live longer than if MRD continues to be positive. And that means it's a good prognostic marker. That's not to say that patients with MRD positive disease are going to have a much shorter survival. Some of them can also live as long as MRD negative patients because they can go into an MGUS-like phase. But in general, all things considered equal, thousands and thousands of patients, MRD negativity is a very, very, very good prognostic marker for outcome. So those are set in stone. I mean, like those are well accepted. What we are trying to figure out is, should MRD be the goal of therapy? And I don't want to answer that question because so many clinical trials are asking that question. You need randomized trials to answer whether if you stop therapy when patients go MRD negative or de-escalate, is that better than just continuing? If the MRD continues to be positive, should we escalate therapy? In patients who are MRD positive, do you keep changing therapy to get to the MRD negative? These are all subject of current clinical trials, and it'll be hubris to think I know the answer before these trials are done. So we have a hypothesis. It's very, very helpful to be MRD negative. And if we have safe enough treatments, trying to get somebody MRD negative without going into the over-treatment angle would be a good thing, particularly for high-risk patients. Even in the absence of phase 3 trials, that's our hypothesis. That's what we sometimes do in practice with shared decision making. But we don't profess to know the answer. At least I don't profess to know the answer to that question.
So if I add to the very good summary Dr. Rajkumar mentioned, is that I think the methods to measure MRD has been standardized. Our goals are clear. We want to get to what we call 10 to minus 6 MRD negativity. Even 5 could be okay if the methods available do not do that day. Number 3, we do strive to get to MRD negativity. But as Dr. Rajkumar says, do we do 10 different treatment changes to get that? Not really, because we do not know beyond a point, are we increasing, as you asked, toxicity versus the benefit of it. But in the initial part, newly diagnosed patient, our hope and the goal is we can get them to MRD negativity. And why? It's because there is clear evidence that if you get MRD negativity, that remission will last much longer, and the patients in general do better than those who do not. It's also a situation where we all agree that high-risk patient, if they get MRD negativity, their outcome gets much better. They almost get closer to what the standard risk patients ends up being. So that's a group where we would strive to do even more to get to MRD negativity. And the final point I would want to make is that we make certain changes in our treatment algorithm based on MRD negativity, or we are beginning to do it. The data is still being generated, which will solidify our general path to its utilization in regular practice. But we do make a decision about how long the induction to give. Number of people are considering MRD as an endpoint to think whether transplant should be done or not. Again, that's not universal, but that's what we all utilize. And also what type of maintenance to give and how long the maintenance to give. Again, none of these questions are set in stone, but that's what we do. Final one point, if you do not get into MRD negativity, that's not end of the world. Many patients who do not get MRD negativity still do well for a long period of time. So those of the patients who may not get it, there is nothing to be panicking about. You may still do very well. And so that would be the general principles we follow. It will keep on evolving to make it even better.
Yeah, I mean, I think if I can add just a little, because I think those discussions were really helpful, and I hope that patients see that it's not a binary, either you're there or you're not there. I think that as with many things in a rapidly evolving field, the impact of MRD negativity or positivity is context dependent. Is it early? Is it late? Is it sustained? Is it standard risk? Is it high risk? Is the number going up? Is the number going down? Those are all contextual variables that we look at when we're trying to assess a given patient in terms of what the meaning for that MRD number really holds. And as an example, we have a very prominent European colleague who's a friend that says, if you're MRD positive at 1 year and you're high risk, you're not going to survive to year 2. Well, I've got an entire clinic of people that prove that theory wrong. And many of them, if not all of them, are in fact high-risk patients, because we treat high-risk patients in a maintenance fashion that is very different than our colleagues or trials in Europe do. And so I think you really need to be at a place that does this a lot, that understands the subtleties and nuances of the context that we just described, and can employ that context to help make the right decision for an individual patient at an individual moment.
I think one more thing to let everyone know, the role of IMF and the I² team effort in getting MRD out to the regulators. IMF led this effort to collect the data from all over the world globally, wonderful collaboration. It was presented to the FDA, presented to the EMA, and because of that effort, now we are able to get drugs approval based on MRD, shortens this time, increases the access to the drug very quickly for our patients. So it's a wonderful effort by IMF.
Well, thank you, Dr. Munshi, for mentioning that. I appreciate that shout out to the IMF and our work. None of that work would have been possible without all three of you here, along with so many other investigators around the world sharing their data with the IMF and allowing us to do this work in collaboration. So thank you to all of you. And thank you for that discussion. I've been seeing a lot of questions come through, and I don't know if you have been scanning them.
Yep.
I'm going to just jump in, but if there's anything in the questions that you all are seeing, please feel free to jump in yourself. I'm seeing one around efficacy with trispecifics, and if there are any results so far around trispecifics in trials yet. And I'm just going to leave these open for whoever would like to take any of these questions.
I think there are two new things that we should keep in mind. One is trispecific. There are two bispecific available, talquandamab and teclistamab. They give certain response rate, but when they were combined, there was clearly increase in response rate, there increase in depth of response. But now it has given way to having trispecific, where the antibody will target two molecules or two targets on myeloma cell. It is beginning to increase the efficacy, so the effectiveness is significantly increased. And there are multiple trispecific coming about. There's trispecific, which is in clinical investigation at an advanced stage, both BCMA and GPRC5D. There is a trispecific, which is now targeting CD19 and BCMA. There is a third one, which is BCMA and anti-CD38 or CD38 targeting. So multiple trispecific are coming because the responses are going up, and to some extent toxicities are also lesser than what we would have found with separating. So great excitement for the trispecific to be evaluated. Hopefully they may replace bispecific one of these days soon once we have more confirmation of the data. They are also being utilized in combination to make it even more effective. And the second advance that there was a question about is the in vivo CAR T cell. And again, we won't go into great details of that right now, but current problem with CAR T cell is that it takes around 6 weeks, 4 to 6 weeks to prepare them. And when we use it at a later stage of the disease, 6 weeks is a long time for patients to wait. The disease progresses. Also with CAR T cell, we have to get what we give lymphodepletion therapy, which has its own toxicity with blood counts and infections and etc. The newer method, what we call in vivo CAR T cell, does not require CAR T cell production. It can be given immediately to patients as we select the patients for this currently in a very early stage of investigation. We do not need lymphodepletion, so toxicity may be different. Again, it's very early days, but we are all very excited to investigate this. So great two advances, which is going to impact how we treat myeloma probably next year.
And if I can, Heather, just we've spent a lot of time talking about bispecifics, trispecifics, and CARs, and I want to make sure that we mention antibody drug conjugates, particularly the BCMA antibody drug conjugate, because it does have an FDA label in the context of relapsed myeloma. And we did see some really exciting data at EHA looking at Bela in combination with DRD in newly diagnosed myeloma with really long predicted progression-free survivals. It does have its own set of side effects that I think certainly we're happy to talk about in more detail. But when we talk about certainly maintenance for high-risk patients, as an example, Ajay Nuka from our center is using Bela in combination with Pomdex as post-transplant maintenance for high risk. And it is so far better than anything we've ever seen before in this subset of patients. So I think it is a very active drug. It's one that is easily available in the community. And I just didn't want to go too far without mentioning it.
I appreciate that. I had a feeling Bella was going to show up at some point, if not in our discussion, at least in the Q&A. So I appreciate you bringing it forward. Dr. Rajkumar, did you want to add anything, or should I move on to our next question?
No, I think that's enough.
Okay.
I mean, there are like a lot of questions, and
There
I think
are a lot
maybe
of
easier
questions.
we can go from the beginning. Otherwise, we'll miss out some questions. That's what I'm afraid of. Like there are people who have started from 7 o'clock with questions. So
the very first question that came in was, is multiple myeloma hereditary?
in general, no. We have shown a slightly higher risk of MGUS, the precursor, and myeloma in first-degree relatives, but it's not hereditary in the sense of the word. 4 per 100,000 per year, even if it's 2 times higher risk, is still only 8 per 100,000 per year. So you're very, very, very unlikely to get myeloma, no matter what the family history is. So in general, no.
And the next question in the Q&A is around the generics for lenalidomide and Revlimid. And are you seeing in practice any decrease in efficiency or in efficacy? And I see you shaking your heads.
Yeah,
so
no.
You feel comfortable with the generics, which are so much more accessible, and especially in other countries and other markets, people should feel confident when their doctors prescribe the generics.
It's the same drug. It's the same chemical. Should work the same.
Thank you. I think that will be very reassuring for that person. Are there any studies or trials that are looking at no maintenance and only treatment-free survival after ASCT for patients with low-risk cytogenics and MRD negative status on day 90? I think you all can see these questions too, so you can see.
We can.
Yeah.
I don't think so, but we are definitely having trials looking at shorter duration so that it's not like maintenance indefinite, like 2 years and stop, 1 year and stop, using a bispecific for 1 year instead of, or 2 years instead of long-term maintenance. So that's going on. I think there's one study which is looking at just induction and CAR T versus nothing. And then just nothing. But right now for post-transplant, all studies have some maintenance.
And I think what that really highlights, because we know that not just the progression-free survival, but the overall survival for patients in a randomized trial getting maintenance versus no maintenance favored the use of maintenance. And so I think with the older classes of drugs that we have, and that includes bortezomib, carfilzomib, lenalidomide, pomalidomide, and the oldest of them all, melphalan, you need some form of ongoing therapy in order to maintain MRD negativity. With the newer classes, the bispecifics, the ADCs, the CARs, it may be a different story. And that's where we're talking about limited duration therapy, but those studies have not been done or are being done now. And so I think our hopes would be that we could get to, as Dr. Rajkumar said, limited duration maintenance, if any, after MRD negativity with those approaches.
And thank you for that. Why isn't more attention paid to myeloma bone disease, since it's such a prominent symptom?
So I think if I say that's not entirely true, and there's two reasons why. So one is that we have very good drugs. There are two classes of drug. We have bisphosphonates and we have denosumab, which is an antibody-based treatment, extremely effective in helping bone disease, increasing or decreasing the bone destruction, allowing bone regeneration to some extent, etc. And we have a very good track record on how to use it. There was a time when there was very big focus for all of us because we did not have all this access to this bone disease targeting drug. But now having that, that's one aspect. The second component is that myeloma treatments have improved so much that continued bone targeting drug is not as necessary. We used to give it every month forever. Now we don't do that. And our guidelines suggest, again, IMWG guidelines suggest limited duration and then much less infrequent use of it. And so I think because of the great improvement in the treatment of myeloma, getting the disease to an extent that no more new bone lesions and or bone destructive activity is happening, the focus has shifted a little bit because we are comfortable with what we are doing. One area where there is still some ongoing investigation is we can prevent bone destruction. Can we increase bone regeneration? That's a little bit tricky biological thing where can we generate more bone? And those areas of research are ongoing, but because of the very great success in myeloma treatment, need to target that has decreased a little bit. The research hasn't stopped. We still are looking at better ways of using it, less toxicity of those drugs, etc.
Thank you. Thank you, Dr. Munshi. So this is a very specific question from a person who's asking if they, with a solitary plasmacytoma of bone at L4, but low monoclonal peak so far at 0.5, be classified as smoldering myeloma. They understand that the plasmacytoma makes them a higher risk, but they are curious if they would still be classified as MGUS. And what it makes a difference to them as to how soon systemic treatment would be helpful. So far, they've only received radiation at the site of the tumor.
So solitary plasmacytoma, there are two types. One is just solitary plasmacytoma where the bone marrow is completely normal. The other one is solitary plasmacytoma with minimal marrow involvement, where there's bone marrow involvement like in MGUS, but less than 10%. M spikes may be present in both, and it usually goes away after the radiation. The standard of care is still radiation to the involved lesion and then wait and watch to see what's happening. In the patients who had bone marrow involvement, we tried to do a clinical trial in the US, randomizing patients to no therapy, which is the standard, versus 6 months of a triplet. But that trial accrued only like 10 or 11 patients and closed, so we still don't have the answer to that. It's a fair question because we are thinking of early intervention for patients who don't even have one lesion, who simply have bone marrow involvement. And so somebody could ask, I've already had a big bone lesion, particularly if it's a big bone lesion. Why shouldn't I get on top of radiation some, if my marrow has got 5-6% plasma cells, some things adjuvant to that? Very individualized decision. I really don't know what the right answer is. I've done it both ways, but it's very, very hard to answer because there's no data. I don't know, Nikhil or Sagar, what you usually do.
No, I think your question is right on spot.
I was hoping you would answer that one.
So our next question is somebody who would like to know about the side effects of CAR T for younger patients, long-term side effects.
Well, so the CAR T cell, the immediate side effects remain more or less similar. And we have had access to CAR T cell now for 6 to 8 years, more so in last 3 to 4 years. The aspects that we are trying to keep a close eye on and evaluate is the effect on the stem cell or the bone marrow microenvironment, where do patients have any risk of developing MDS-like changes? These are all under investigation. And because young patient and with myeloma treatment, the way it is, patients live very long. These are the side effects which are closely monitoring. At the current time, I would not say that there is any specific extra risk for patients getting CAR T, whether they are young or they are in the older age group. But ongoing evaluation for any bone marrow stem cell related issue, any what we call MDS and chip-like changes that are coming up in the bone marrow. The blood counts is a good marker. That's what physicians would follow, and one should keep in mind. The other malignancy-related occurrences with CAR T cells are too infrequent to be of concern at the moment. But with any gene therapy-like studies, we are obliged to follow patients for 15 years, and that is ongoing. No red flags there, especially even for younger patients. So I would keep an eye on the usual thing, but nothing specific for a younger patient in following CAR T cell. Remains same across the board.
Okay, well, thank you. I'm sure that will be very reassuring. Do patients with a 1Q amplification have less BCMA expression?
Not really.
No.
I don't know.
Okay. So here's an interesting question. Is a stem cell transplant an option after CAR T, or would CAR T preclude a later transplant using stem cells that were harvested before their CAR T?
Yeah.
So in general, there's not a reason to exclude based on CAR T exposure beforehand. I don't know that many folks have done that yet. We've probably seen the reverse done more often. You've had a transplant and then you end up getting a CAR, and there's a high risk protocol currently going on where you get quad induction, you get a transplant, and then you get a CAR T after the transplant. So that version is being looked at more, but there's nothing about getting a CAR that would preclude you if you already had stem cells harvested from getting a transplant at another time. The benefit may not be quite as good. That's the only issue.
Okay. Thank you for that, Dr. Lonial. We have a question about what new research and or treatments are available for high risk, especially with the T1416 and with a gain of 1Q.
So that's a very specific question. Also, I guess somebody is more personally interested in this question. As the new IMWG definition that came about, 1416, which used to be considered high risk, was not considered high risk by itself. It's only high risk if it is with 1Q or 1P. So having 1Q would put the group into higher risk. There are many nuances in the biology side for 1416. That's a disease where there are more mutational changes. There are different other things on one hand. But on the other hand, there is also newer data that says it may not be as high a risk as we thought in the past. So I think it's a unique situation. So a lot of genomic studies being done to understand what's happening with 1416 translocation. There is a MEF involvement. That's one of the gene in that locus. What does it do epigenomically, etc. So a lot of interesting research is ongoing, but the therapeutic angle remains very similar currently for this patient population.
Okay, thank you, Dr. Munshi. Again, another very specific question from a person who's on cycle 3 of Kyprolis and dexamethasone. They're asking about, they're stating that when they fall out of remission, they plan to have a CAR T. And they recently watched a webinar that mentioned that patients after 3 cycles have weaker T cells. And they want to know if there's something they can do to actually strengthen their T cells.
I don't think you can do anything to strengthen the T cells, but I wouldn't think like that, because if you look at the CARTITUDE-1 study, some patients had like 7 treatments, 8 treatments, 9 treatments, like median was like 6, I think. And a third of them were progression-free 5 years after the CAR-T was done with cilta-cel. So and I think the median is not that different between the CAR-T at 6th line and CAR-T at first relapse, which tells you that in spite of multiple treatments, our T cells are pretty robust. And as long as the BCMA target is there, and patient's not extremely frail with very, very low counts, you should have the same effect or similar effect.
The only thing I would add to that would be that the T cell collected soon after some previous treatment may not be as functional. So to give enough time from the last treatment to T cell collection, and that would improve the T cell health to some extent. But as Dr. Rajkumar said, there is nothing that would be that's possible to increase it. Just let the T cell give little time. Don't need years of time, weeks or month between the last treatment. And there are certain treatment which have more effect on any cell, including T cell, and avoid them as the last treatment, like bendamustine or melphalan, so that or Cytoxan for them to recover.
Yeah, I mean, I think there are, again, a lot of variables that impact the efficacy of a CAR. So how much BCMA is expressed on the cell is one variable. What is the microenvironment that the myeloma cell lives in is another variable. The third variable is T cell health. And the fourth variable is how much myeloma is in the body at the time you administer the CAR. And so it's almost a little bit like the blind man and the elephant. We think we know what the right answer is, but there's so many factors that can influence outcomes. You want to have the greatest impact on the most, recognizing that you may not be able to control all the variables. And to me, the one driver, and I'm curious what my colleagues really think about this, is we actually try and go into the CAR with less myeloma if we can, and that seems to have a better outcome in general. And so I think there again, it's not as simple as don't make your T cells weak. I think there are many things that are part of that.
Thank you. So we're hearing from another person who was diagnosed in 2024 with standard risk myeloma and has had a quad therapy and a stem cell transplant. They're currently in remission. Since that's been the standard of care for 5+ years, they want to know what the data is indicating for what to expect moving forward for them in terms of PFS or OS.
Well, the thing is, it's what we know for sure is that a young standard risk patient, less than 65, who's had a transplant and is getting maintenance therapy, currently 80% plus 82, 83% are progression-free at 4 years. At 5 years and 6 years, it's going to be a slightly lower number, but I don't want to make any projections, but at least it's a pretty good odds of being progression-free in 2030. Okay? And we already know at first relapse treatments are giving you 80% progression-free at 3 years. So at least 7, 8 years, there's a really, really good chance of being progression-free with 1 at the most 2 regimens.
That's a great perspective, and I'm sure very helpful way to think about it. And it takes people outside of that constant sense of worry. So thank you for providing that perspective, Dr. Rajkumar. With the emergence of cell mods, how do you anticipate integrating, and this was kind of discussed before, so I'm still going to read it though. How do you anticipate integrating these agents into your treatment strategy for patients with relapsed refractory disease or after multiple prior lines of therapy?
I mean, I think it's going to be all over the map. I think we're going to see attempts at integrating IBR and MESI into earlier lines of therapy as partners with proteasome inhibitors, as partners with anti-CD38s. I think you're going to see it as we already see data combining it with elranatamab. Both IBR and MESI have been combined with elranatamab, which is a BCMA bispecific. So I think it's going to be used in a number of different settings. What I'm actually really excited about is the idea, to get back to that CAR T cell weakness question, if you can give Iber or Mezi for a few weeks before you apheresis, have you changed the phenotype of those T cells in a way that allows them to be better CARs? That those kinds of studies are going on right now, and that to me is a really exciting way to think about reversing concerns about T cell health.
Interesting. Thanks for sharing that. So if a high-risk patient achieves MRD to the -6 and stays there, would you still recommend a stem cell transplant?
This is a hard one. I mean,
Yeah.
but in general, yes, because MRD negative, I think, still doesn't mean 0. It means that is the level at which we can detect with our methods right now. We still believe the MRD negative patients, many of them have clonal malignant cells left behind. That's why relapses occur. And high-risk patients are particularly at risk for that. So I don't want to take a chance. We know that high-risk patients do well with quad transplant doublet maintenance. The Emory 1000 study is a great example. I'm not going to change that unless somebody shows me proof to the contrary, that you don't need the transplant.
Yeah, and I think what we also know about high-risk patients is that they achieve deep responses, but they don't get sustained. And so if you're saying, if this hypothetical question is, they're in MRD negative CR at cycle 4, how long would I need to see sustained MRD negativity to not talk about the transplant? It would be so long that you should have just already done the transplant. That's sort of, and I can see Nikhil is going to disagree, so I want to hear his answer.
I think the question comes, this is a very, very well-crafted question. It says
Yes.
10 to -6 and stays there. So what is the duration of stays there? So somebody has not given treatment for a while, and he has remained MRD negative. Now, if it is MRD negative for 2 months or 3 months, I think my colleague's points are very correct. However, if he was MRD negative for 1 year, I think there is something to true high-risk disease, MRD negative for 1 year, not recurrent anywhere. I think he is doing well. And beyond that, I think whether we do transplant after 1 year of being MRD negative, it's something debatable. I would not say don't do it, but I think it is something where we can debate.
Yeah, and the thing, Nikhil, is that this is the conditional probability, right? Like somebody has, for whatever reason, not had a transplant for a year.
Correct.
Okay. Then if you see such a patient, then yes. But
Correct.
prospectively, when you see a patient and their 4 cycles induction done, they are MRD negative, I would still recommend the transplant at that point.
Correct.
Which
The
is
debate would be even more intense if the patient said, I'm standard risk, MRD negative, and then would you do transplant or not? And my esteemed colleague, Dr. Lonial, might say, well, I might still do it. And I think there is no wrong answer. They're both right answers.
Right.
Yep.
So thank you for that. That was great to hear the different approaches and perspectives. Are there any trials or studies investigated treatment-free surveillance, no maintenance treatment for standard risk patients who come out of ASCT with MRD negativity?
I think we answered that in the previous.
We already answered that.
Yeah, we already answered that.
Okay, so the next one is, if you started on a 3-drug therapy, a triplet, RVD, and you were on that for 6 years and have a 1Q amplification, would you recommend switching to the 4-drug stem cell transplant or CAR T if the M spike is increasing?
That's a hard one.
So the thing is that it's this kind of very specific patient-related question is hard to answer. If a patient's progressing, that's a first relapse, and we would do whatever is the appropriate treatment for first relapse. And so we have good guidelines on how to start initial therapy, good guidelines on what to do for first relapse, and what to do for second relapse, and so on. So I think I'd stick to that rather than going to a very, very specific patient question like this.
Yeah, and his motive was to say if 1Q is a high risk, it's not currently considered high risk by itself. 1/3 of the patient has 1Q.
Yeah.
Right.
Okay, thank you. I think that's probably very reassuring to that person. The next question is, when we talk about high-risk patients going toward transplant in order to achieve MRD negativity, do you think the functional high-risk individuals or those who have extramedullary disease are in that category? Do you include those with high risk and extramedullary disease in the category?
So, I mean, I think extramedullary disease, true extramedullary disease, likely falls in the category of high risk already. And we know that those are more challenging to treat even with the best of therapies that we have. The functional high risk question is a little bit difficult to answer because by definition, functional high risk means you've relapsed earlier than we think you should have relapsed. So you've already relapsed. And that's a slightly different question than the high risk patient about going to transplant, whether or not they have extramedullary disease. Functional high risk, to me, in an area of quadruplets with no other high risk features on initial sequencing or FISH studies, means that they've relapsed within 5 years. Because we expect the remission in a quad with a transplant to be longer than 5 years. And so a functional high risk patient would be somebody who relapses earlier, and then you're thinking about how do I manage first relapse, similar to the previous question.
Okay, thank you, Dr. Lonial. Go ahead.
I was going to say that I was just monitoring this right now. We have another 35 minutes left, but we have another 50 questions to go. So we may have to just do 30-second answers, or like at least someone has to scan the questions to pick them. Because there's like, we are up to 73 questions right now.
I know, it's been quite a response, so that's very exciting. So
this is different than when we give talks to our colleagues, where there might be one person asking a question.
So I'm going to ask the IMF team if you guys can scan for things that are perhaps not specific to individual patients, because those are the slightly more difficult to answer, but maybe we can actually... Go ahead.
Let's do 22. What about older patients in their 70s? Are they candidates for CAR T? So Nikhil, why don't you?
Yeah, so I think patients who are receiving CAR T cell, the age limit is not similar to what we do in transplant. Truly, there is no age limit. We have all done patients beyond 80 with CAR T cell. They need to be in better health in certain ways. The cardiopulmonary function, the frailty should be improved. We have done patients up to 30, 85 or close to it with CAR T cell. So it is a very individual decision, but there is no fixed number restrictions on CAR T cells with age. 70 definitely is not. Up to 80, we all do without even thinking much. There's a question that is interesting, question number 20, which says the panel has mentioned a cure several times and the advances have been made are allowing us to reach that goal in the future. Are there a subset of patients currently that fit a cure status and have been evaluated for genomics and other features?
So I don't know the answer to the cure piece, but I can tell you we just pulled our exceptional responders, patients that were in remission for greater than 10 years, some of whom met the IMS definition of cure, some of whom were still on maintenance therapy, so didn't meet that definition of cure. About 85% of those patients who were in remission, and this is with RVD, this is with triplets, not with quads. 80% of those, it's about 200 patients, I think, in our series. 80% of those patients had ISS stage 1, standard risk genetics, hyperdiploidy, nothing extramedullary of concern. Interestingly, somewhere around 10% did fit into our previous definition of high risk. They had 17p deletion and got aggressive 3-drug maintenance, or they had karyotypic abnormalities at diagnosis in 15 to 20% of cells, so a more proliferative myeloma. A few of them actually did well at 10 years as well. So while it does fit those people we think are going to do well, there can be patients who don't always fit that definition that can do well if they get aggressive treatment for high-risk disease. But Nikhil or Vincent, you guys may have more data.
No, I think your answer was perfect.
I went all the way to the end, and because there are like 4 or 5 very easy ones. Trisomy 17 plus 1q, is it high risk? No. GPRC5D CAR T, is it likely to produce the same side effects as the bispecific? Maybe, but milder, right?
Milder, yeah.
Milder.
It seems to be less. That's correct.
Yes. And then what do you do for patients who have failed BCMA bispecifics and the standard ones? And that's why we are looking at GPRC5D, CAR-T, and mezigdomide, iberdomide, GPRC5D bispecifics, and probably even FCRH5.
Yeah, that's what I was going to say. FCRH5 is coming back as well, and I think that would be another really exciting piece. And I think the question, and I'll go quick because you told me to go quick. The question is, why did the BCMA drug not work? Was it loss of a CAR, like over time, lack of persistence, or was it receptor mutation? Those are things that need to be looked at now when patients progress on a BCMA.
I think one question that's here I think we should handle this really quickly because it's important, which is what is the risk of Parkinson's from CAR-T and what are we doing about it? This is something that's weighing on people's mind and we have to take it, straight on.
Yeah, so I think that's part of the late neurotoxicity more often observed with cilta-cel. That happens around day 92, around 3 to 4 months around time. And it is not fully reversible, and that is the seriousness of it. I think there are things to be done to mitigate this problem. That most of the people who are working on CAR T cells, meaning administering CAR T cells, are now very familiar with. One of the critically important question is to decrease the disease burden, as Dr. Lonial suggested, that getting a lower myeloma burden before CAR T cell, that's one of the things to do. The second is to look for it by various testing, by making people write something, what we call micrographia, etc. So at the earliest sign of some change, you would want to treat this patient. So there are mitigating measures one could do to decrease the incidence of Parkinsonism. And I think that will remain a critical component of this reasonably serious, not as reversible side effect that we observe. I think one of the questions asked is that would love to see what you think is question about MRD resurgence. If you're MRD negative and now become positive, do you act? What do you do?
Well, generally we've been treating patients when they meet like IMWG criteria for progression or symptomatic progression. So this MRD resurgence, negative becoming positive, is such a minute change. And the question is, treating at that point may mean treating like a year earlier than you would have otherwise done. And doing so, did you actually help the patient or not? This is a question Dr. Kaufman from Emory has designed a clinical trial for, which is, should we treat at that point or should we treat like we have always done? And I don't think we know the answer for that, Nikhil.
No, I think you are right. And currently we don't make changes just because you become MRD positive. We all have many patients who become positive but stays low positive for a long period of time without needing any change.
But what if somebody has like this high risk disease and
exactly,
double hit like kind of patient, negative for a long time, now it's become positive?
Yeah, only caveat is truly high risk, ultra high risk, then I would be much more careful. When somebody asks, would you do bone marrow every 3 months? We would not do bone marrow every 3 months. I think.
But I might, if somebody goes from negative to positive with like 100, I might do another marrow in 3 or 6 months to see where they are. And if the trajectory of that curve is concerning, I might intervene in a high risk patient like that.
Correct.
Yeah. Yeah. Can you become MRD negative after second line therapy? Absolutely. Yes. I think even in relapse setting, MRD can still remain the target.
Early relapse is the newly diagnosed myeloma.
That's a good one.
I think people will be repeating that.
Yeah, there's a question about, this is an environmental question, and what kind of epidemiologic studies are being done about myeloma incidence in cities. Someone says they live in a rural area of Oregon and there seems to be a high number of patients. Is this something we should think about? I will tell you, we have, I did a study once because there's one area in Minnesota where we found like multiple people in the same street with myeloma and lymphoma, very close to each other. And there's been concern about pesticides that were sprayed in the 50s. And, it takes so many years before you start seeing any changes. So someone exposed as a child, for example, right now, whether they'd be at high risk and so on. But in general, other than some studies generally saying exposure to pesticides, petrochemicals, and benzene and things like that increase the risk, I don't know if any of this is more than just coincidental.
Yeah, I think the only one where there is some evidence and some connection established is in the veterans population who are exposed to Agent Orange.
Yes.
And I think that Agent Orange exposure and the connectivity is reasonably well established, again, by a more epidemiologic type of studies, but it is high enough. And also there is data that what was in the Agent Orange can induce some changes in the cells, etc. So that's one thing that is, people worry about the big power lines near their home. They do not cause myeloma, but that's quite often the question asked.
But I will say, certainly in rural Georgia, pesticide exposure among farmers seems to be at a higher risk. We have carpet factories north of Atlanta, and we see a fair amount of plasma cell disorders among patients seen in that area. So there probably is some chemical exposure. I don't know what it is specifically, but that probably has a role.
And the question was about urban versus rural population. In the veterans population, that has been looked at and didn't make big difference whether urban or rural population.
There are several questions here asking about smoldering, and I think obviously, Vincent, you might want to take some of it, but I think one take-home message about should I be treated or should I not be treated. I've seen many emails from patients asking me, my doctor's recommending DARA for my high-risk smoldering, and I look at the numbers and they're actually low-risk smoldering. And so I think the definition and criteria for what makes you high risk is something that really major myeloma centers are comfortable understanding that definition. It's still a little bit new to many practitioners who don't see quite as much myeloma. And so if you're thinking about early intervention, which I think is reasonable in the right patients, I would suggest you get that second opinion to make sure that you fit that criteria. But Vincent or Nikhil, you guys may have other thoughts.
Yeah, and there's one other person who said we are not looking at cytogenetics as a risk factor in these patients. Actually, that we are, and this, if you know the cytogenetics or if you even know the genomics with whole genome sequencing, you can get a better risk prediction. I can make a plug for a website we have called myelomarisk.com, myelomarisk.com, and you can type in the actual numbers of the M spike, the cytogenetics. It's very, very simple to enter. And you get an approximate what is the risk of progression at 2 years. The closer that number is to 50% or higher is where we will start thinking about early intervention. And sometimes I'm surprised that, borderline numbers like 2.1 gram and 21% plasma cells look like they're meeting the high risk criteria, but the risk of progression is much lower. So you can do some, and there we are taking into account cytogenetics now. It's not in the 2-20-20, but when I see a patient, I'm taking into account the cytogenetics, taking into account their hemoglobin, their not just whether the bone marrow is more than 20%, but how high. Is it 30%? Is it 40%? 50%? That's all more than 20, but each one will have a different impact on our decision making.
And I think what you pointed out about the genomics of smoldering, as you mentioned, I think they're going to become important as we have more data collected and more granularity of what that means. It might become more important than many other features we have currently. There is a question, when you add more drugs, tri and quads, most patients, the person writing questions says, I coach, worry about adding more side effects. Quality of life is also a concern for patients. Any comments on quality of life and treatment?
Well, I think if you look at the tri-specific, for instance, versus the bispecifics, the GPRC5D side effects are lower with the tri than they are with the bispecific. The frequency of administration is less with the tri-specific than it is with the bispecific. And so I think those are positive signs from a patient's perspective in terms of what they're experiencing. If you look at the in vivo CAR versus the typical ex vivo CAR, it looks like the adverse event profile is different. Whether the remission duration holds up, I don't think we know. But I think one of the hopes with newer technologies is that we do address not just efficacy, but we also address safety and quality of life. And at some point, we're going to have to make decisions on what's more important. Is efficacy more important, or is quality of life more important, as we get products that may be similar, or one may be less effective as measured by PFS, but the quality of life or toxicity is lower. That's a complicated discussion to have with a patient in terms of what you would recommend in any given situation.
I think one of the questions Heather had asked in the beginning was a very astute question about MRD and quality of life. Do we sacrifice quality of life to get to MRD? And the answer, we answered partly, but not fully. But now that we're talking about quality of life, I think when we try to get MRD negativity, we are very cognizant of how much drug we give. We don't go overboard. What we do is standard, and in the process, we try to get it. We did a study where patients who got MRD negativity versus those who did not, they were at very similar, in fact, quality of life. In fact, patients who became MRD negative had improvement in their quality of life. So I think if your physicians are trying to get you to MRD negativity, they are not sacrificing one versus another quite often, and that trying to get to MRD negativity still can allow you to maintain a good quality of life.
So Sagar, you mentioned the smoldering myeloma. There are two questions. One is a very general question, which is more information on smoldering with regards to DARA, and the other one is, should I use linvoseltamab to treat smoldering? And I'll just tell you, so the only drug that's approved for early intervention is daratumumab. And if that's not available, the only other drug that I would consider would be lenalidomide, which is a trial that Dr. Lonial led, which also shows ability to delay the progression. In the DARA trial, 3 years of fixed duration DARA, if you look at the proportion of patients who started full myeloma therapy, that was 40% at 3 years in the watch and wait arm, and only 20% in the DARA arm. And so you can delay significantly when you start the full myeloma therapy by using DARA. Anything more than these two is really experimental. You could potentially put yourself at risk. You could benefit. Who knows? And that's CAR T-cell, linvoseltamab, ASCENT-2 type of ASCENT type of protocol, CSER type of protocol. These are all not verified against in a randomized trial to be superior. We are doing these trials in the hope that they will be better, and eventually they will have to go through a randomized trial to know. So those should be done. CAR-T, linvo, all these should be done only as part of a clinical trial with informed consent. Other questions? I'm also scanning through. We've done really well.
So there are three questions on T-cell fitness and T-cell exhaustion. So people asking questions are very astute about immunology and use of CAR T-cell. I would just give a very brief answer that those are very much within the research purview, which we all three of us are involved in studying. And what it simply means is that how effective the T-cell in your body are, or are they getting the T-cells getting tired because they are being treated with lots of bispecific, etc. And as Dr. Rajkumar mentioned earlier, we are beginning to give not as often. The prescribed duration or frequency might be one, but we are beginning to change it so that the T cells remain functional. We get best out of what we are treating. And so those are research. We don't routinely perform it for clinical practice, but on the research side, we are all working on it to make it more applicable to day-to-day practice. Not standard practice currently in our clinic.
And one question, Nikhil, I mean, these are the basic questions we should answer. Can you just say what is the current IMS IMWG high risk definition so people know? Because someone's asked what is high risk myeloma?
Yeah, I saw that question. So there are 4 things which are considered high risk according to the new criteria. Patients having 17p deletion with 20% what we call clonality or cells, or they have p53 mutation, either of them. Patients who have this 3 translocation, T414, T1416, or T1420, not alone, but with either deletion 1p or with amplification 1q. So that's the second. And the third criteria is that patients have loss of so deletion 2p biallelic, meaning on both the chromosomes, or they have one chromosome with deletion 1p and they also have simultaneous amplification of 1q. These are the three conditions which make high risk. The fourth one is that patients have a very high beta-2 microglobulin, 5.5, with normal renal function. That's our current definition. So what used to be high risk with just 414 translocation, not anymore. You need something else with it.
And for Sagar, is Iber less toxic than Revlimid?
I mean, it appears to be there. The head-to-head study is just completed enrollment comparing Iber versus Len in maintenance. But certainly in the preliminary studies, it appears to have much less non-hematologic side effects like fatigue, diarrhea, that sort of swimmy head feeling you get from a CELMoD. So it does appear to be less toxic than Len or POM. There's questions here about BCMA, soluble BCMA or BCMA expression measured before administering a BCMA targeted therapy. So my answer to that would be, if it's the first time a BCMA agent's being given, you probably don't need to measure it. But if you're talking about retreatment, we actually look at sequencing of BCMA. That's probably, I think, the better way to look at it. Soluble BCMA tells you whether it's there, but it doesn't tell you if it's mutated. And the immunohistochemistry test is not very good. So I think sequencing is the best way to go about that.
Yeah.
There's one question I want to take on, which is the belantamab question, because we haven't talked about that drug. See, this belantamab, we haven't talked about for first relapse because it's not approved for first relapse, but it is approved for second relapse. So when you go to second relapse, we do consider belantamab along with bispecifics, CAR-T, and standard triplets as options, and then we decide based on what patients have had before which one to go with. And the question here is, are the ocular side effects from belantamab reversible? So the side effects of these, the ocular side effects are really related to the dosing. If you keep giving it frequently, then these emerge. And now we are going to be giving it not every 3 weeks, but maybe every 3 months. Yeah. And so, or 2 or 3 months. So you might have much less. Also, people know that these are reversible by and large. So that's the simple answer to that question.
Yeah, agreed. All right, we have 3 minutes.
Yeah. Yes. Heather, you have new questions?
So there are some interesting questions that have come in toward the bottom of the list as well. One of them is around if there are any new drug approvals expected in spring of 2027, given what has been read out or what you anticipate being read out between now and the end of the year, perhaps at IMS later in the fall or at ASH later in the year.
The drugs which are closer to, hard to say when exactly. But linvoseltamab is already out there. I think we will have a CAR T cell, anito-cel would become available. I think as Dr. Lonial mentioned, mezigdomide and iberdomide are moving quite well. And I don't want to put the exact date. We don't know, it would be 27, 26, it could be a little bit later. But these are the drugs which are very close to, they have shown excellent efficacy. They're just waiting for final readout, etc. And then there are other targeted things. GPRC5D CAR T cell is one. The trispecifics are moving, not probably for 27, will take a little bit longer time. But these are also very close to, in this decade, these are the drugs, both the two trispecific, which look quite promising. And then there are small molecule, for example, venetoclax and its new version targeting the same is moving quite fine. They might become available at some point for our utilization. So a lot of promise. We expect at least 5 to 7 more drugs to be approved in next 2 to 3 years.
Which is, I think, really a spectacular high note for us to end on, because as we spent a lot of time talking about everything that's happening in terms of what's in clinical trials now, what we can anticipate seeing. And that's a really great place, Dr. Munshi, to close on by focusing on how many more treatments are coming soon in the very, very near future, with more coming even behind those. So thank you for giving us that very hopeful note to end on. So, gentlemen, thank you all. Thank you all three of Dr. Rajkumar, Dr. Munshi, Dr. Lonial for an incredibly illuminating session. I think that our audience has been treated to a very unusual webinar where they've been able to have so many of their individualized questions answered. I think it's something that the IMF tries to do, which is to allow more people access to our specialists, to our experts. And I appreciate that the leadership of the IMF and the IMWG, that you've all made yourselves available, so much time available and so late in the evening, especially for Dr. Munshi and Dr. Lonial on the East Coast. We're grateful to everybody who stayed with us. And I think it really is just a testament to how much is happening in the myeloma space, that no matter where you are in the myeloma experience yourself, there's always cause for hopefulness. And the IMWG and all of the experts around the world will continue working hard with our industry partners. Once again, thank you to our sponsors, GSK, Johnson & Johnson, and Sanofi. We're grateful for your support to help us bring our three specialists to all of you tonight. We look forward to seeing how all of this information continues to come forward and will be translated in the future into clinical practice in the coming months and in the coming years. And we wish you all a very good evening. Thank you.
Good evening. Thank you.
Thank you.
Thank you.